Let's begin. So, pharmacologic management for patients with special healthcare needs, or, let's drug them if they bug us, right? No, that's not appropriate. But unfortunately, sometimes I feel like that's kind of what happens, which you'll catch on as we go through this. You'll see why I would say something like that. Again, I don't have any financial relevance. So we talked about restraints and we talked about stabilization. We talked about, non-pharmacologic, non-restrictive techniques. We've talked about restrictive techniques. And one of the things with restrictive techniques, similar to what you see in the picture here, and we talked about, we're restraining somebody. But is this also a restraint? And the answer is yes, this is a chemical restraint. And so the Public Health Code federal regulations has always considered this a restraint, and they define it as a drug or a medication when it's used as a restriction to manage the patient's behavior or restrict the patient's freedom of movement and is not a standard treatment or dosage for the person's condition. And I think that's kind of the key part of the sentence right there. If somebody takes a sedative medication on a regular basis to get out the door as part of their overall, behavior medication regimen or psych regimen, that's different than specifically giving them a drug for the dental office in order for them to be treated in the dental office or a medical office or somewhere else. So that's really where that sticky wicket comes in. And bring that up. So, commonly, these are prescribed for patients that have physical, behavioral, or emotional limitations. And it's to help limit unwanted movements. But we need to remember that we have to try stabilization first, hence why we've gone through all those previous talks and talking about what we're doing. And many see stabilization as a restraint, like I said, but they don't see pretreatment drugs as a form of restraint. Sometimes it's to improve their ability to cooperate or prevent aggression. No assessment of why there's the resistant behavior. Is it fear, pain, frustration? I often hear you won't be able to get anything done without knocking them out. So is it a habitual use with without a proper reassessment? Have they just always given this person drugs because that's what they're used to doing? And when was the last time anybody tried without? And we have to remember not all treatment environments are the same. And so very often, it may decrease the patient anxiety, or is it the dentist, the staff, and the caregiver anxiety? So I always used to take that statement and say, challenge accepted. Watch me, see how much I can get accomplished without sedating this person. And it's always been a struggle to get staff, family members to understand, please do not bring them to their first appointment with a sedative medication on board that you gave them specifically for the dental office. Because how can I know what they need? And they'll say, oh, well, their doctor prescribes it. Well, that's a whole nother problem, right? So it's prescribed by a medical doctor for all their appointments, or is it just for dental appointments? So it's based on their behavioral assessment in their office. It may be based on a behavioral assessment by the psychologist or the psychiatrist, but rarely is it based on observed behavior in the provider's environment, meaning my environment. You're in my office. I've learned all these other techniques to help me be able to help you cope with the appointment. And I'm not going to try to rush through this and get you in and out the door in 30 minutes. If it's going to take a long time with little baby steps and taking lots of breaks and letting you get up and walk around and all that kind of stuff that we've talked about, I'm going to let you do that because I'd rather take the time to let you become acclimated and desensitized than to start just saying, oh, you won't sit in the dental chair. I have to give you a drug. Because to me, that's not a safe offense option. And the other problem is the way these drugs are administered. So not only are they being prescribed by somebody else who isn't going to be there, by the way, to manage the patient should there be an overdose, a medical emergency, or some other problem. So when I'd hear, well, their doctor prescribed it, well, that's great. I can prescribe the medication. I have that license. I can prescribe it. The problem is that when someone else prescribes it, and then the patients now, as soon as they cross my threshold, they're my responsibility, not that person's responsibility. And getting family members and caregivers and agencies and stuff to understand that is sometimes extremely difficult. Every state, every city, every country has their own rules about what requirements you need to do sedation and general anesthesia. And so to assume that it's okay to just give somebody a drug and send them off to the doctor's off to the dental office because somebody else said it was okay doesn't mean it's okay for the doctor. And I've had to have those discussions, and you heard me raising my voice because it's just so frustrating because it happens all the time. So what often happens is the drug is administered by family or staff before they even arrive at the dental office. Those people administering and with the patient, very often their emergency management and training is limited. They may not have proper rescue equipment or drugs are not available for transport. The number of people needed for a transport can vary. And then there's also the concerns that they don't have a way of managing the side effects, the fall risk, the airway compromise, the cardiovascular and central nervous system depression. So the people administering and managing the person before and afterwards, especially our complex patients who already are in danger of problems with aspiration and, altered sense of balance, and they're already a fall risk. They already can have a compromised airway because they're postured, in that head down posture. Um, so it's dangerous. And I've got to share the story, and I'll try to make it real quick because I know we don't have a ton of time. So, I had someone and I said, you have to wait till you get here. And they're like, well, it takes us so long to get here. And then by the time the drugs kick in, yada, yada, we're here all day. And I said, well, okay, so if you give it to them in the car on the way here, how would that look? Well, we would just pull over and give it to them, an hour before we're going to get to the office, which happens all the time. I am not kidding you. And I said, well, okay, so then let's say you have a medical emergency. The person's airway becomes compromised. What are you going to do? Do you have oxygen on the van? No. So what are you going to do? Well, we'll go to the nearest emergency room. Okay, okay, sounds good. How many did you pass on the way here? I'm sorry, how many did you pass in the last hour of your trip? How many emergency rooms did you pass? I don't know. How close were they to the highway? Because you took the interstate. How many, did you notice, and where would you have to pull off? And how long would it take you to get to the hospital if the person's having an emergency? I don't know. Okay. And how long does it take when you've compromised somebody's airway and you've cut off oxygen to the brain? How long before you start seeing permanent brain damage? I don't know. 10 minutes would be a stretch. Okay. It's usually considered to be a 6-minute time frame. So when I brought it in that perspective, they seem to have a better understanding of why this was not a good idea. So we're able to regulate the dosage sometimes. So we're going to talk about quickly advantages and disadvantages to IV sedation or general anesthesia. So, whether you see this as an advantage or a disadvantage is going to kind of depend on your situation and your personal feeling and how your office and everything is set up. So, we have the ability to regulate and titrate the dosage during deep sedation or general anesthesia. The deep sedation may require airway management, and that requires a recovery room to be supine, etc. We may be bringing an anesthesiologist or a nurse anesthetist into the office, which may have issues considering space, the number of professionals. Usually, in order to provide, you need a approved site visit. There's usually extra training and certifications needed, and the cost of that training, the time, and the need to constantly be renewing that training. And you usually have to train your staff beyond their usual duties. Some may not want to. You may require an OR or an inpatient capacity, and many Many of the newer guidelines are saying that it should be done in a outpatient setting where there's immediate access to a hospital or emergency access, because usually the problems occur when it's not in a hospital setting. And then, usually the patients are MPO from the day before. And as we know, patients with behavioral issues, food is everything very often. And if they're going to miss a meal or two meals, it's going to accelerate their aggressive behavior, possibly make them even more combative or less cooperative. And it's going to kind of muddy the waters as to whether or not the medication was helping. You can use the now we're, oral or enteral sedation. Okay, we don't have the ability to IV or general. So let's talk about oral sedation. Everybody does oral sedation, no big deal. Well, it's kind of a big deal. Again, you can use it for mild to moderate sedation. The patients can maintain their own airway, and it can be used across all ages and weight ranges. But this is where things become a problem. You have to know the lowest effective doses and you have to know the maximum recommended dose. And in that lowest effective dose, how often do you have to administer it before you find that sweet spot? You start low, then you need another visit, got to do it again, another visit, got to do it again. And what are the other factors that could be causing it to not be as effective? So, administration is, when we administer it, we're counting on the usual time for the onset of action. During oral sedation, you cannot titrate dosages, and sometimes people will stack the dosages, which becomes very unpredictable. Let's say I give you a drug at 10 o'clock, thinking it's going to start working at 10:30. 10:30 rolls around and you aren't sedate yet because most of these patients, especially with special abilities. They're on all these other medications. Very often it may not work as planned. So half hour rolls around, they're still not sedate. So you say, okay, we're going to increase the dose and you give them another one at 10:30. Well, now the 10 o'clock dose kicked in at 11 o'clock and that 10:30 dose is going to kick in at 11:30 and those two together, now you've double dosed the person and you've overdosed. And so you have to be very cautious about stacking. And it's safer if you're going to do this, give them one. And if it doesn't work today and all other factors are equal, give them more on another day. Do not stack doses because it's too easy. You've got to see what is their reaction. How long does it take them to react? How long does it take to get it out of their system? Now, it can be administered sublingual as a liquid or a slurry. That's usually, if you can manage that, you're going to get a faster absorption, which is going to be helpful. I used to do that with my Halcyon. I grind it up in water and try to kind of get it underneath the tongue there, or I'd put it into a thicket solution or a little bit of applesauce, and we kind of stick it under the tongue and try to get it so it was kind of staying there. If you make it real thicky with that thicket, they can't swallow it very easily, and it kind of sits there a little bit and gets absorbed a little better. They can be administered with a small amount of food, again, a small amount of food. And the onset and efficacy, like I said, is going to vary. It's hard to regulate what the dosage amount should be. There's going to be variations in onset and could cause a delay in treatment for the day. Let's say you're counting on it taking 20 minutes and now it's 40 minutes in and they still aren't sedate. And then it's 60 minutes in and they're just kind of starting to get a little groggy. You're going to have to be able to go with the flow. As we've learned with these patients, most of it is go with the flow if you want to be successful. Patients can receive oral sedatives in the office under the supervision of a trained person, which is always the better way to go. Unfortunately, as I mentioned, they're used to administering it during transport. The administration time is usual time for the onset of action. Patients are usually or need to be NPO 6 hours prior to the appointment in order to prevent aspiration, to make sure that the drug that is absorbed and it isn't interfered by food, and whether that's a single drug or a drug combination. So, a lot of times, what happens is if you haven't set up a protocol that includes NPO, If the patient ate and then you gave them the drug, you don't know if it wasn't working because there was so much food in their stomach it wasn't absorbed, or if there wasn't any food in their stomach and it was quickly absorbed. And so what happens is, oh, it didn't work, we'll up the dosage, but you forgot to ask if they just had a cheeseburger. That could be a problem. You need to have an area in the clinic where the medication can be administered and the patient monitored while the drug is taking effect. And that monitoring has to be done by a trained person who can, recognize that there's a medical emergency, act accordingly, get you, and you have to have, eyes on or within, the area to have eyes on, which every state again has different regulations. But you need to be able to be, there in that fast because that's how fast things can go bad. Less monitoring equipment is usually needed because they're able to maintain their own airway, but you must always be prepared to be able to treat and rescue from a higher level of sedation than planned. So if you're planning mild to moderate sedation, you need to be able to rescue from moderate to deep sedation. And if you're planning mild to deep, then you better be able to rescue from deep to general anesthesia. What are you going to do if that patient falls into a state of general anesthesia and is no longer maintaining their own airway? Do you have the ability to rescue them from that circumstance? And so usually there's extra training, and a lot of times agencies have to have lock boxes and count the pills, et cetera, which they sometimes say it's easier for them to do it at the house because everything's locked up and ready to go, and they don't have to worry about transporting it, et cetera. But again, we already talked about the dangers of doing that. So the drugs themselves, mostly the benzos are used for oral sedation. I'm not going to talk a lot about IV sedation and general anesthesia, other than the way that I touched on it, because I don't do it. It is something that requires so much extra training that for me to get into it here in this limited amount of time is not um, helpful. But in general, the benzos, the benzodiazepines are the ones that are our kind of our stay, have always been taught. Everyone's told, oh, Valium the night before, and then give them a little Valium before they come, and they'll be fine when they're there. Again, that depends on your patient. It depends on the reaction. It depends if they can have somebody with them. And in the patient, this has to be a case by case assessment, especially consider the comorbidities and the physical challenges that many of our patients have and their ability to self-regulate. We have to be able to help them stay alive and breathing and not getting oversedated or hurting themselves or becoming unmanageable as a result of the drugs that we've given. So these are metabolized in the liver and usually excreted in the urine. Um, Good thing to understand though is because of this enzyme here, the concentration can be increased by grapefruit. That's why they always say no grapefruit products, no grapefruit if they're taking benzodiazepines because it can increase the amount in the system. So you think you gave them 20, but the body thinks you gave them 30. Not exactly, but you get it. Okay, benzos. What are some of the adverse events? Now, the anterogate amnesia, some people say, well, that's the advantage. They aren't going to remember that they've had this procedure and everything. Okay, but if you're trying to teach them how to be a patient without needing it, that can be a problem. We have CVS, depression, cardiovascular. We already know that. We already have compromised patients, and we're going to get that hypotension. And as we all know, the biggest problem when a medical emergency is when that blood pressure starts to tank, the respiratory system shuts down and they stop breathing. And then we have our central nervous system depression as well, which can lead to the respiratory and the central cardiovascular depression, right? So it's when the system starts to slow down to the point of unconsciousness that we have to be um, concerned. So the central nervous system depression, we have to remember, okay, so impaired mental abilities, that's a good thing when we are dealing with somebody that's what we're trying to do is to make them not as aware of what's going on. They can have a paradoxical reaction where suddenly they become aggressive, or acting out more than what they might normally. And I'm going to give you my theory on that, which I haven't been able to test. And then there's the impaired physical abilities. So we already have people with impaired physical abilities. They may have a gait challenge, they may use a walker, a wheelchair normally, and now we're going to increase their fall risk by giving them something that's going to make them groggy and slow down their overall reaction time. So you have to have reversal agents available, must be able to rescue from the next highest thing. Now, okay, so I'm just going to throw this out at you. There are no studies to be able to test this necessarily in this population, even though I'd like to. I might try to figure it out. If you come up with a study design, let me know. We'll do it together. So I want you to imagine that you're somebody who already doesn't quite have a full comprehension of what's going on around you. And you are normally very apprehensive about going places, going to the dentist, whatever. And you're having your normal day. And then all of a sudden you become disoriented. Maybe your vision's a little off. You're feeling unsteady. You're not, understanding what exactly is happening. And you don't know why you're feeling that way. You don't know somebody gave you medicine that's supposed to make you feel that way because you don't understand that. So imagine you yourself are out drinking with friends and you're the one who's, the designated, and somebody accidentally slips you a gin and tonic instead of a tonic, and you drink it and you don't notice it, and all of a sudden you're feeling the effects of the alcohol. Or somebody slips you a Mickey. Now, y'all know what slipping a Mickey is, right? Somebody gives you medication that you're not aware they gave you, right? So all of a sudden you're becoming disoriented, you're becoming drowsy, you're losing your sense of self, your orientation in space, time, those alert by three, but you don't know why that's happening to you. Okay. Would that make you a little aggressive? A little, if the drug itself didn't overpower you, do you think that might make you more upset and aggressive and you might start acting out because this is happening to you and you don't know why? You need help? So that's my theory sometimes when some of these patients become aggressive or, you get this paradoxical effect and they're fighting it and fighting it. Are they fighting it because they're trying to be difficult or are they fighting it because they're scared to death? Because now you've introduced another level of the unknown. So that's my theory. And you think it through, kind of makes sense, right? If you can figure out how to test it, let me know. All right, so these are the drugs we usually use, different names, different times. These are the most common ones. They're starting to talk about how Xanax isn't all it was cracked up to be when it was first being prescribed for depression and anxiety and all that good stuff. Most people are overusing it. And I don't know if you know this, but withdrawal from Xanax is like withdrawal from heroin. It's horrific for people. So these are the dosages that we usually use. These are the onsets of action. This is how long it takes to peak. So, as I was saying earlier, it may have an onset of 15 to 30 minutes, but it's going to reach its peak at, the 2 hour mark, right? It may go on 20 to 30 minutes, but it's going to peak at 1 to 2 hours. Again, 10 to 20 minutes, I'm circling the wrong one, 2 to 3 hours, right? And the bioavailability of the drug is going to be changing as these times go on, right? And then what's the half-life elimination? How long is this drug going to stay in their system? Because this half-life, during this time, they're going to be fed or not. They're going to get other medications or not. They're going to go home and, oh, they're tired. They were, sedated for the dentist. Just let them go to sleep. So they're going to be unmonitored as the drug is possibly peaking and there's still a huge amount of the drug in their system. And now no one is monitoring them anymore. So those are the other concerns we have to have when we're giving people these medications. Then we run into the combination agents. So people start adding extra drugs to be used with the benzos because it can increase the pain threshold, help maintain a relaxed state. They'll use nitrous oxide, which is one of the safest analgesics we have available, because it can be administered on its own or with a sedative medication to enhance the effects. No residual side effects from the nitrous necessarily. Oftentimes, opioid medications are added to have that not only the added sedative effect, but some pain relief. If you add some pain relief to the sedation cocktail, you're adding, that's one of the things everyone's afraid of, right? And you'll notice as soon as you touch them, they respond, they're back. Here I am, you hurt me. And it's like you never gave me anything at all. And then they have to go back down again. And sometimes antihistamines are used as well. I will say that with the nitrous oxide, and I'm just going to pass this along. So you have to keep in mind if you're using nitrous oxide for many of these patients, they can't breathe through their nose with their mouth open at the same time. Um, physically, often, I shouldn't say they can't, period, but often they can't do that physically. And often they don't understand that is what they need to do. So you need to keep that in mind, and you may have to increase the rate of flow liters. What's their tidal volume, which may registered in a relaxed state to be 5 liters, but because their mouth is open and they're breathing through their nose, they're not breathing through their nose. You may have to increase the volume of air being passed in order to kind of shove it down down the oropharynx and get it down where it needs to go, right? The other thing to keep in mind is that sometimes the normal limit, we don't like to go above 30-40% on the nitrous. You may have to go as high as 40-50, or percentage, because again, a lot of it's being blown off and they're not necessarily getting it down into the respiratory tract where it needs to be disseminated systemically. So you need to have a good scavenging system, but you need to keep in mind that you may have to really up things because so much of it is not being sucked through the nose. And you may have to constantly remind them to breathe through their nose. So those flavored masks or scented masks can be helpful if the person administering the nitrous just keeps reminding them, smell the oranges, smell the oranges, let me see you smell the oranges, smell the oranges. And they just keep repeating that mantra to help make sure they are breathing through their nose. Okay, so rules. Everybody hates rules. You must obtain, whoops, sorry about that. You must obtain informed consent, including all the risks and benefits um, associated with the drug that's being given, the interactions it can have, the effects it's going to have systemically, the benefits of having the drug, making it more cooperative, et cetera, the risks, including, death. The benefit is getting the needed dental treatment without, letting it fester until the person dies from the infection or the risk of, anesthesia killing them. I mean, that seems extreme, but it's out there. Someone recently, there was a report recently, I forget where, of someone who died from a tooth access due to lack of access. So another DeMonte driver situation. We have to try a less restrictive management method first. So the whole time we've been talking through all of these different managements, we've said the least restrictive first. And those, in my mind, include the physical, mechanical, um, restrictive techniques before going to a chemical restraint. Because, restraint is restraint, but one, when you're finished, they're back to baseline. The other, when you're finished, they're not back to baseline for hours. And that's where you reach that danger zone. You have to specify a time period that the consent is going to be valid for. Most people will go with a year, and usually in the consent, you may have a varying dosage range as you're trying to figure out what works. You have to have a dated signature by the prescribing provider. That means the person prescribing the drugs and recommending the sedation be used for the patient. Now, sometimes I found that if I tried to get the signature from the psychiatrist or the doctor that was prescribing these drugs on my consent form, about, the risks, the benefits, and, responsibilities of prescribing, et cetera, they didn't necessarily want to do that. They're more than happy to prescribe the drug and have them take it in my office, but they don't want to have to sign something saying they're aware of the dangers of doing this and sending them to my office. So I always found that a little interesting. Have a dated signature of a legal guardian or and preferably a witness documentation of that. And if you have to do some other form of consent, make sure it's witnessed, documented, dated, all that good stuff. You want to specify what modalities you're going to be used and for what duration. So the duration of the dental procedure, the duration of the, how long you're going to administer the drugs, how long those drugs may have an effect. You want a list of the interactions. And this also goes for the restrictive techniques as well that are not pharmacologic, saying, okay, we're going to use this. Now, if using a less sedative drug with a restrictive technique, like if they take, a very low dose of something, just enough to get them to get into the papoose and stay papoosed and not be overly or detrimentally affected by the papoose, then that's something often that people would recommend as well. And again, it's a balancing act, whether or not you're comfortable, whether you've got all the things you need. Because remember, when you release them from the papoose, that should be it. But if you release them and they're on a drug, that's going to make monitoring the effect of the stabilization on top of the medication difficult to sort. Always have a written protocol to give patients and caregivers that has to be read, signed, and kept in the patient chart. And that should be done before and day of, and again, as a post-operative, please take this with you. More rules. Caregivers and patients need to notify you of any changes at least 48 hours beforehand. There is nothing worse than when individuals show up, they've got the book, you've already, prescribed the medication, and then all of a sudden, oh, by the way, now they're taking X. Well, X interferes with what we prescribed. Did it occur to you to call me before you gave them the prescription? you know, happens all the time. Oh, the nurse will tell us if there's a change. Well, the nurse needs to tell you of that change 2 days at least before the appointment so they don't take the drugs ahead of time. Have the patient take all their regular medications. You don't want to mess up their normal chemistry by holding something. So be aware of all the interactions. But also along these lines, regular medications. Is it possible to work with their physician, their psychologist, psychiatrist, whoever might be prescribing some of the medications that help keep them calm or help them sleep at night? Is it possible to possibly alter the timing of when they're taking those medications? If instead of taking it at bedtime, if they were to take it at 4 in the afternoon for a, 5 o'clock appointment or whatever, and it's a medication that might help you be able to better manage the patient, or if they take it first thing in the morning, how long does it take for it to have effect on their behavior during the day? Let's find that sweet spot and bring them back at that time. So always look at the medications they're taking and ask yourself, how can you maybe best manipulate those meds instead of adding another med to the mix? They're already on a, cornucopia of drugs. Let's try to limit the number and not add more to the pile. You must have an accompanying adult. You must have, the patient NPO. Of course, there might be exceptions. Some patients with diabetes have to eat. Some people have to have a little food with their medications. A little food. A little is the key point there, right? Don't give them waffles and sausage for breakfast, but a little applesauce is going to be okay. Have the patient toilet before, you get them going, because once they're sedated and you have to move them, you've added another point of movement and possible falling. And generally, when they start to become more relaxed, they may become more bladder relaxed and they may end up having an accident inadvertently because, you're not paying. Oh my God, do that before nitrous. There's nothing worse than in the middle. I've got to go to the bathroom, and you're taking them down. They go to the bathroom, they come back. You got to bring them up again. Just a standard, make it a thing everybody does. Have a wheelchair to return them to the transport vehicle when you're finished. And unfortunately, if they are gonna, you're gonna let them do the sedation in the van and then come in, have a wheelchair. Don't let them walk the person into the office. Make sure they use a wheelchair. Good. They were good and tired in the van. I don't know what happened. Well, you walked them 20, 200 feet in the freezing cold before you got them in, and then you had to wait, and then you had to get up in a wheelchair, in the elevator, and then you were sitting. I mean, that's what happened, right? Make sure you have the vitals and the level of consciousness has returned to baseline before letting people go, and make sure that you are recording throughout. You must monitor vital signs. They must be recorded throughout the procedure in 15-minute intervals. You want your blood rate, your pulse. You want your blood pressure, your pulse, your respiratory rate, and your oxygen saturation. And this oxygen saturation is not called the pulse ox. The machine that measures the pulse and the percent oxygen saturation are called a pulse ox, but the numbers are not a single number. And it's important that you're making that distinction and reporting both numbers. Um, Critical. And remember that the O2 saturation, by the time you measure it, it may be long after the person has started to have a respiratory distress. So you must be watching for those other signs where they suddenly look as though they're not breathing, they're getting that blue around the lips and all that other stuff that would indicate you've got an airway emergency, whether the person is sedated or not. And you should always let your malpractice company know that you're going to be utilizing conscious sedation and what modality, and that you've got all the proper certifications and everything. It's better to be proactive in that sense if there was a problem, or they may tell you what are some of the consent forms and everything that they want you to know or use if you're going to have that in your office. So be aware of that. Medical emergencies, you all get more than enough training on what to do for medical emergencies. I just want to talk a little bit about the reversal agents. So, if you're going to be doing any sedation, you want to make sure that these reversal agents are not only present, but they're pre-measured and available on the counter in the room where you are working. So, for the benzos, you've got your flunarizumab. It can be given IV, it can be given you can repeat 1 minute over interval up to 4 times, maximum dosage of 1 milligram. The maximum 3 milligram dosage in a single hour is really the new measure. I'm sorry, I meant to remove this portion. But it's available in zero point 0.5 per 5 milligrams and 1 milligram for 10 ml IV solution, and it's usually administered IV. You may not have an IV in place. Remember that the mouth is a highly vascularized area, the tongue, highly vascularized, floor of the mouth. We're used to injecting things there. We do it all the time. Lots of vessels there. Give it a squirt. The opioids, the naloxone, which is Narcan, you should have in your office regardless of whether or not you're using the opioid yourself, because people come in on opioids for many different reasons. And it may not be your patient, but the person bringing the patient who ends up going into an overdose. So have it available, know how to use it. The intranasal is a full, it's there, it's a squirt, it's in. It does come in IM or sub-Q, just like doing an EpiPen. And then the IV, if you do have an IV, it's a slow push over time. So, in summary, pharmacologic intervention is a full body, multi system restraint. So, don't ever think it isn't. There are risks versus benefits, including possible death from either lack of treatment, oversedation, or injury. We should try less restrictive modalities. And once someone has had a full mouth rehab under general anesthesia, I cannot stress the importance of getting a proper care plan in place with good preventive measures so they don't need to return to the OR or continually be sedated for dental treatment. We can take them from this environment to a home office environment with proper planning and proper care plans in place. And we're going to talk more about that next time. As always, I thank you for your attention